Now, after having discussed about the nephrotic syndrome, then we'll move on to the discussion of nephritic syndrome. So if you see this nephritic syndrome, we have a clinical entity called proliferative glomerulonephritis. In this proliferative glomerulonephritis, number one, we have nephritic syndrome. The other one is rapidly progressive glomerulonephritis. Okay, so proliferative glomerulonephritis. The two components in this proliferative glomerulonephritis will be, number one, nephritic syndrome. The second one is rapidly progressive glomerulonephritis. What is the difference between these two, nephritic syndrome and rapidly progressive glomerulonephritis? Nephritic syndrome, they develop acute renal failure. Right? Where there is development of renal failure within days to weeks. Then RPGN, right? It is rapidly progressive glomerulonephritis, where these patients, they will have subacute renal failure, where there is development of renal failure within right. So in case of RPGN, that is rapidly progressive glomerulonephritis, the type of renal failure that you will have is subacute renal failure, where the individual develops renal failure within weeks to months. Okay, that is in RPGN. Now, in both of them, that is in nephritic syndrome and rapidly progressive glomerulonephritis, the presentation will be, they will have nephritic urinary sediment. The clinical manifestations will be, or presentation will be same in both of them, but the only difference is the rapidity with which there is development of renal failure. Okay, next. Subnephrotic proteinuria will be there. In case of nephrotic syndrome, the proteinuria is almost more than 3.5 grams per grams of, sorry, more than 3.5 grams per grams of the creatinine excretion. Whereas here it is around 3 grams per 24 hours. And they will also have oliguria. So to call it as oliguria, how much should be the urine output? How much should be the urine output to call oliguria? They will have edema because of proteinuria. And then hypertension, right? Very good. So it is 400 ml per 24 hours. Okay. So these will be the manifestations in case of the proliferative glomerulonephritis, right? So both of them, they together, we have nephritic and RPGN. Now, to call it as RPGN specifically, there are two. Okay. Before that, what does this nephritic urinary sediment contains? The nephritic urinary sediment, it contains RBC and RBC cast, right? There will be also WBCs, that is leukocytes, and proteins will be there anyways. So this is what the nephritic urinary sediment contains, right? What are the three essential features? Presence of your hypertension, then the hematuria, and as well as the hypertension, hematuria, and subnephrotic proteinuria. These three are essential for the diagnosis of your nephritic syndrome. Hypertension, this is number one. Next, hematuria, and then subnephrotic proteinuria. These three are essential for the diagnosis of the nephritic syndrome. Now, to call it as RPGN specifically, right? What are the points in favor of only RPGN? So to call it as RPGN, two features should be there, right? Or there should be two important criteria. What are those? Number one, there should be presence of epithelial crescents, right? There should be presence of epithelial crescents. What is epithelial crescent? It is the half moon shaped collection of the cells. It is half moon shaped collection of the cells. Right, half moon shaped collection of the cells. That is what is called epithelial crescents. And these epithelial crescents, they are present in almost 70% of the glomeruli. These epithelial crescents, they are present in almost 70% of the glomeruli. And what does these cells? They are nothing but your epithelial cells or your inflammatory cells, that is your WBCs and all. And second important in the criteria of the RPGN is occurrence of rapidly progressive renal failure. Right, occurrence of rapidly progressive renal failure. Okay, so these are the two criteria which are required to call it as RPGN. Now, what are the causes of your RPGN or your nephritic syndrome? So now what is the difference between these two? The difference between the nephritic syndrome and RPGN is it is only the rapidity with which there is development of the renal failure. In case of nephritic syndrome, the renal failure, it will be within days to weeks, whereas in subacute, it is like weeks to months. Okay, right. Now, yeah, I'm coming to that, Kamal Nathan. I'll be discussing about the individual etiologies now. I'll answer your question once we discuss about the PSGN, right? So, if you take the etiologies that will be causing rapidly progressive glomerulonephritis or nephritic syndrome. So what are all the etiologies that we have under the RPGN? First important is the infections, where you have deposition of the immune complexes, post-infections. Right? Next is we have some multi-system diseases. Right? Multi-system diseases. Then followed by that, we have drugs. Okay. So these are all the causes which we classify. The post-infections, right? Kamal Nathan, I'll come to your question. When we discuss the PSGN, I'll take your question. So we have post-streptococcal glomerulonephritis and as well as the infective endocarditis. Multiple system diseases. Okay, you take this infective endocarditis, right? We have discussed this in the cardiology also. Can anyone tell me what is the most common organism causing infective endocarditis? most common organism causing infective endocarditis? Anyone? Not Streptococcus viridans, Vinita. Not Streptococcus viridans. Yes. The most common organism causing your infective endocarditis is none of you. We have discussed this, right? That is Staphylococcus aureus. Staphylococcus aureus, that is the most common cause for your development of infective endocarditis. Followed by that, you get the Streptococcus viridans and the remaining all story. What is the most common organism that will cause infective endocarditis in IV drug abusers? That is again Staphylococcus aureus, and it has as well as the fungal infections like Candida. Okay, Staphylococcus aureus and fungal infections like Candida. Okay, now what is the most common risk factor for the development of infective endocarditis? Jacob, it is diseased valve only, but which particular diseased valve is the question? Yes, which particular diseased valve? That is your mitral valve prolapse. That is your mitral valve prolapse. Okay, so mitral valve prolapse, that is the most common cause or most common risk factor for the development of the infective endocarditis, right? And these patients with infective endocarditis, what are the examination findings that you will have in the hand? Examination findings in hand: Osler's nodes, that is in the pulp of the fingers; Janeway lesions, what is that you will observe in the nails? Splinter hemorrhages. Very good, Kamal Nathan. One more important finding. The other important finding is, apart from splinter hemorrhages, clubbing. The other important is clubbing. Clubbing can be there. Can anyone tell me one more cardiac condition where you can have clubbing apart from infective endocarditis? That is, you should tell it as cyanotic congenital heart diseases, right? Jacob and as well as Vinita, you said tetralogy of Fallot. It is not only tetralogy of Fallot, all your cyanotic congenital heart diseases. Tell me 5 important T's, or what are all the various examples of cyanotic congenital heart diseases? Very good. Tetralogy of Fallot, then transposition of the great arteries, total anomalous pulmonary venous connection, then still 2 more T's are there. Over. Tetralogy of Fallot is over. Tetralogy of Fallot, yes. So truncus arteriosus and tricuspid atresia. So totally 5 T's. I'll just repeat again. So one is TOF, right? That is tetralogy of Fallot. Second, truncus arteriosus. Third, transposition of the great arteries. Fourth, total anomalous pulmonary venous connections. Fifth, tricuspid atresia. These 5 are cyanotic congenital heart diseases where you can have the presence of clubbing, right? Then coming to the multiple system diseases. Multi-system diseases which will be causing your rapidly progressive glomerulonephritis or nephritic syndrome is, that will be Goodpasture syndrome. Right, Goodpasture syndrome. Then we have some connective tissue disorders. These connective tissue disorders are systemic lupus erythematosus. Can anyone tell me what is a nephrotic syndrome that is seen in SLE? What form of nephrotic syndrome is seen in SLE? SLE can cause both. Very good, Jacob. It is membranous glomerulonephritis. Okay. Then, can anyone tell me the examples of small vessel vasculitis? Examples of small vessel vasculitis. Small vessel, Jacob, polyarteritis nodosa is what? That is not a small vessel vasculitis, right? Very good. One is your microscopic polyangiitis. One more. Yes. So, Wegener's. Then, what is GPA, Jacob? One is Wegener's. The other one is Henon-Schollen's purpura, microscopic polyangiitis. The other one is Church-Strauss syndrome. These four are your small vessel vasculitis. Out of which, in Wegener's granulomatosis, you can have, right? You can have this rapidly progressive glomerulonephritis. The other one is Henon-Schollen's purpura. These are the two conditions. Then, what are the examples of medium vessel vasculitis we have discussed? What are your medium vessel vasculitis? Anyone? Polyarteritis nodosa. Even polyarteritis nodosa, you have your rapidly progressive glomerulonephritis. Yes. The other ones are Kawasaki disease and one more. What is one more example of your medium vessel vasculitis? You said PAN, you said Kawasaki. One more is there, na? Buerger's, very good. That is your thromboangiitis obliterans. Very good, Soumya. So now, but the one which will cause multi-system disease, which is causing progressive glomerulonephritis, that is only PAN, polyarteritis nodosa. But we have another Buerger's which can cause nephritic syndrome. So what is this Buerger's? Any one of you? Yes. So this will be IgA nephropathy. Okay. Whereas this Buerger's is thromboangiitis obliterans, which is medium vessel vasculitis. Whereas BR is your the one which will cause the proliferative glomerulonephritis. So how to remember this? In your Buerger's of thromboangiitis obliterans, you have this letter U, and U and V, they are like friends with one another in your alphabets. They are like adjacent to one another, right? So your Buerger's, it is a form of vasculitis. This Buerger's, it's a form of vasculitis where you have U, which is nothing but thromboangiitis obliterans. Okay. Now, these are the multiple system diseases which will cause the nephritic or rapidly progressive glomerulonephritis. Then we have drugs, that is penicillamine. So can anyone tell me, penicillamine is also associated with which form of your nephrotic syndrome? Penicillamine is also associated with which form of nephrotic syndrome, right? That will be your membranous glomerulonephritis, because we have discussed many drugs like gold salts, penicillamine, captopril, NSAIDs, probenecid, trimethadione. These are all the one which will cause your membranous glomerulonephritis. Okay. Now let us try to take up the discussion of the first, that is Goodpasture syndrome. Then I'll be taking about the discussion on the Buerger's. Then I'll be discussing about the post-streptococcal glomerulonephritis. Okay. Now we were having a doubt, that is PSGN, does it cause the nephrotic syndrome? See, PSGN, it is predominantly, most of the times, it is your nephritic syndrome. Yes, Kamalnathan, PSGN, it is most of 95% or 98% of times, it is nephritic syndrome. Very rarely or occasionally, there can be nephrotic syndrome. What is that basically? Difference between nephritic and nephrotic? The range of proteinuria is different, that's all. Almost all the features are same. Even in one of the form of your nephrotic, you have hematuria also. that is focal segmental glomerulosclerosis. And even in PSGN, you are having the hematuria, cola colored urine will be there. The only difference between your PSGN nephritic and nephrotic is the quantity of the proteinuria. Very rarely or occasionally, you can have the PSGN presenting as the nephrotic. Otherwise, it is predominantly the nephritic. Okay, next. Now, let me take up the discussion of the Goodpastured syndrome. So Goodpastured syndrome, right, as the name itself is telling you, it is a multi-system disease. And what are the organs? Right. So the terminology what has been given is not appropriate, but in case of nephritic, it is within days to weeks. But in RPGN, it is weeks to months, right? The terminology they have given was not correct, but RPGN definition is within weeks to months, and nephritic it is within days to weeks. Okay, right? It is like a misnomer, right? You take the Goodpastured syndrome, as I was telling you, it is a multi-system disorder. So, what are the multiple systems which are affected in Goodpastured? That is lungs and as well as the kidneys. These are the two important organs which are affected in case of the Goodpastured syndrome. And how is it described as? How is your Goodpastured syndrome described as? It is antibody mediated, right? So here you have in Goodpastured syndrome, you have circulating autoantibodies. These circulating autoantibodies, they are targeted against alveolar basement membrane and glomerular basement membrane. Right, the antibodies are targeted against alveolar and the glomerular basement membrane. So alveolar basement membrane lung and glomerular basement membrane kidney. And these antibodies, they will initiate reaction. It's an autoimmune basically, autoimmune disease. So they will initiate right they will initiate the inflammatory reaction, and this inflammatory reaction is against the basement membrane of the glomeruli and basement membrane of the alveoli. Now, because it is antibody mediated, right? Because it is antibody mediated. So now tell me, what type of hypersensitivity reaction is this? Because it is antibody mediated, what type of hypersensitivity reaction is this? Anyone? Very good, Hari. So it is type 2 hypersensitivity reaction. Type 2, Rohita, because it's antibody mediated, right? It's a type 2 hypersensitivity reaction. Now, these antibodies, I said you they are targeted against the alveolar and glomerular basement membrane, but they are targeted against which component? They are targeted against which component of the alveolar or the glomerular basement membrane? They are targeted against, remember, against alpha 3 chain of type 4 collagen. Right, they are targeted against alpha 3 chain of type 4 collagen. Okay, now once the antibodies are formed against alpha 3 chain of type 4 collagen. What will be the problem in the kidney and what will be the problem? So, what will be the manifestations in the kidney and what will be the manifestations in the lung? So, in the kidney, there will be development of rapidly progressive glomerulonephritis, and because of which these patients they present with hematuria. Right, they present with hematuria, and in the urine examination, they also have nephritic urinary sediment. Presence of nephritic urinary sediment, and there will be also subnephrotic proteinuria, and ultimately they progress to rapidly progressive renal failure. Right, rapidly progressive renal failure. Now, what is the age at which these patients they have the manifestation? The age is 5 to 40 years of age. And if you take male to female ratio, now tell me, this autoimmune diseases, they are more common in males or females? Yes, they are more common in females, but in case of the good pastures, there is slightly variation. The male to female ratio is around 6:1, right? Now, what will be the changes that appear in the lung? In the lung, you will have focal necrosis of alveolar walls, right? Focal necrosis of alveolar walls. And this focal necrosis of the alveolar walls, it is associated with intraalveolar hemorrhage. Right, associated with intraalveolar hemorrhage. Now, what will be the clinical features because of your intraalveolar hemorrhage? That will be hemoptysis, right? And what will the lung show? Lung shows the presence of bilateral infiltrates. And these bilateral infiltrates, they are like diffuse. Okay, diffuse bilateral infiltrates that will be there within the lung. Whereas in the kidney, it is in the form of rapidly progressive renal failure, right? Then, how will you work up these patients? That is the investigation. So, in the workup, important is serology. So, in the serology, what is that you will make out? The antibodies, right? You will be able to pick up circulating anti-glomerular basement membrane antibodies. Right, circulating anti-glomerular basement membrane antibodies. These antibodies are formed against alpha 3 chain of type 4 collagen. And what is the sensitivity of these antibodies? Sensitivity of these antibodies, right, it is more than 90%. Okay. Then, what does the X-ray shows? X-ray shows the presence of diffuse bilateral pulmonary infiltrates. Then, what is the investigation of choice? The gold standard will be renal biopsy. Okay, that's a gold standard investigation. Now, what does the renal biopsy show? You will notice that there is diffuse proliferative glomerulonephritis, right? Then followed by that, you will have the presence of linear deposition of the immunofluorescence. When you do in the immunofluorescence, you will notice the presence of linear deposits. What are these linear deposits? There is the antibodies, right? Linear deposits of the antibodies. And in more than 50% of the glomeruli, you will have the crescents. Right? Crescents are observed in more than 50% of glomeruli. Okay. So this is the workup that you will do in patients with the Goodpaster syndrome. Coming to the treatment. After the workup, you need to know how to do the treatment. So in the treatment, what is very important here is you have to filter the antibodies. You have to take out the antibodies from the body. And that is nothing but plasmapheresis. Okay. So in the plasmapheresis, what is that you will do? This plasmapheresis removes existing antibodies. Right, we'll remove the existing antibodies. Okay. Then after plasmapheresis, the next important is corticosteroids. What these corticosteroids will do? These corticosteroids will suppress the new antibody formation, right? And these corticosteroids should be given simultaneously in combination with the azathioprine. Right? These corticosteroids should be given simultaneously in combination with azathioprine. So this combination, what it does, it will stop new antibody formation. Right? Then, now we have an alternative as well. Apart from your corticosteroids and as well as azathioprine, the alternative combination which can be given to control the inflammatory response is so either corticosteroids plus azathioprine or corticosteroids plus cyclophosphamide. And this combination of corticosteroids and cyclophosphamide, even this will prevent new antibody formation. Okay. Now, apart from this corticosteroids, azathioprine, and apart from corticosteroids and cyclophosphamide, for suppose you have given these two combinations, but the individual is refractory. Still, the patient is having that antibody formation. So, in refractory cases, you should give a monoclonal antibody that is rituximab. Right? This has been used in small number of patients with refractory diseases, right? And overall, the prognosis in these patients is good. But those patients with oliguric acute kidney injury, right? Patients with oliguric acute kidney injury or who require dialysis. Right? Patients with oliguric acute kidney injury or those individuals who require dialysis at the time of presentation. Why they are requiring dialysis? Because of severe form of kidney injury. So these two scenarios, they are considered to have poor prognosis. Right? They are considered to have poor prognosis. So this is about your Goodpasture syndrome. So Goodpasture syndrome, just remember, it is a multi-system disorder, right? Where there is involvement of lungs and kidney. And what exactly is their involvement? The circulating autoantibodies are formed against alveolar and glomerular basement membrane, and particularly which component? Formed against alpha-3 chain of type 4 collagen. And these antibodies, the kidney involvement will be in the form of hematuria and lung involvement will be in the form of hemoptysis. And it is diffuse intraalveolar hemorrhage, but the necrosis is very important. It is focal necrosis. And it's more common in males rather than females. And it's a type 2 hypersensitivity reaction. How do you work up these patients is serology, where you will find the circulating anti-glomerular basement membrane antibodies, and the sensitivity is almost like 90%. Next is your X-ray. X-ray will show you the presence of diffuse pulmonary infiltrates. And renal biopsy, it's like gold standard, right? This will show you that there is diffuse proliferative glomerulonephritis. And on immunofluorescence, you will observe the linear deposits of the antibodies. And you have the crescents. And these crescents are present in more than 50% of the glomeruli. And what are the crescents? That is half moon shaped collection of the inflammatory cells or epithelial cells. That is what is called crescents. The treatment, first you need to remove the existing antibodies, that is by plasmapheresis. Followed by that, right, you need to give immunosuppressive therapy to stop the new antibody formation. That is steroids plus azathioprine or steroids plus cyclophosphamide. The individual is refractory to that, then you need to give rituximab. And patients with oliguric acute kidney injury or who require dialysis at the time of presentation, they have poor prognosis. Okay. So that is about the story related to your Goodpasture syndrome. Now, let me discuss about the post-streptococcal glomerulonephritis. So post-streptococcal glomerulonephritis, as the name itself tells you, that it is a disorder which is occurring secondary to your streptococcal infection. And streptococcal what? Streptococcal throat infection and streptococcal skin infection. But you take this rheumatic fever. What is the difference between this rheumatic fever and as well as the PSGN? Anyone of you? What will be the difference in the streptococcal infection of PSGN and streptococcal infection of rheumatic fever? The difference is that post-streptococcal glomerulonephritis. Okay. The difference is that you take rheumatic fever due to toxin. Okay. Both of them are sequelae only. Yes, Kamal Nathan. Time of onset. Specific strains. Okay. So let me tell you that post-streptococcal glomerulonephritis, it can follow both. It can follow group A beta hemolytic streptococcal, throat infection and skin infection. Whereas rheumatic fever, it will follow only group A beta hemolytic streptococcal throat infection, not follows the skin infection. That's an important difference, right? Rheumatic fever, it follows only group A beta hemolytic streptococcal throat infection, whereas PSGN, it follows both group A beta hemolytic streptococcal throat and as well as the skin infection, right? Now the points are, you take the rheumatic fever. What is the most common structure affected in rheumatic fever? What is the most common organ or structure affected in rheumatic fever? Not valves. Not valves, Jacob. Very good, Kamal Nathan. It is joints, right? Yes, Hari, right? Jacob, right? So that is joints. So migratory polyarthritis, that is the earliest and most common manifestation in patients with your rheumatic fever, right? It is not your, the second will be your cardiac involvement, and that cardiac involvement will be in the form of pancarditis, where you'll have pericarditis, endocarditis, and pericarditis, myocarditis, and endocarditis. That will be your cardiac involvement, right? Then what will be the skin involvement in patients with rheumatic fever? Skin involvement. Anyone? Subcutaneous nodules. Very good. One more. Apart from subcutaneous nodules, they also have erythema. What, Vinita? Erythema nodosum or erythema something else? Right. So erythema marginatum, because in the options he will give you erythema nodosum, where you will get confused. So erythema nodosum is not, it is erythema marginatum. That is what you need to remember. And what will be the CNS manifestations? CNS manifestations in rheumatic fever, that is Sydenham scoria, right? What will be the minor criteria in rheumatic fever? Minor criteria. Very good. So minor criteria will be in the form of fever, raised ESR, raised CRP, prolonged PR interval, then one more, polyarthralgia. Arthralgia will be there, right? Whereas arthritis is major criteria, arthralgia is minor criteria. Okay. And in rheumatic fever, what is the drug of choice for arthritis? What is the drug of choice that you will give for arthritis? That is your high dose salicylates. But Jacob, for example, if the child has developed Ray's syndrome with aspirin, what is the alternative drug? Yeah, we give naproxen. What we give is naproxen. And you are giving NSAIDs, that is your aspirin or naproxen, but the inflammation did not reduce. Then what is the alternative drug? Very good, Vinita. You need to give steroids. You need to give steroids. Okay. Then you take the recurrence. How will you prevent recurrence in case of rheumatic fever? How will you prevent the recurrence in rheumatic fever? Which penicillin, Vinita? That is benzathine penicillin. Benzathine penicillin should be given. What is the route of administration? IM or IV? Benzathine penicillin. Deep IM. That's very, very important. Deep IM should be given. Okay. Not if you give IV, the individual will have anaphylactic shock and death of the individual. Okay. Right. So that is about your rheumatic fever. And if the individual is allergic to penicillin, what are the alternative drugs? Yeah, sulfadiazine. The other one is erythromycin. The other one is erythromycin. Okay. So that was about your rheumatic fever. Now let me take up the discussion of your post-streptococcal glomerulonephritis. So post-streptococcal glomerulonephritis. Okay, one point again. Your rheumatic fever. So is it, what type of hypersensitivity reaction is that? Type 3. Very good, Vinita. So even your PSGN, it is the immune complex depositions. So this is also your type 3 hypersensitivity reactions, right? So PSGN, it is the immune complex disease preceded by streptococcal group A beta hemolytic streptococcal infection, then followed by that staphylococcal infection. Okay, but most commonly it is group A beta hemolytic streptococcus, and this is predominantly seen in children, right? Predominantly seen in children, and it is the one which follows group A beta hemolytic streptococcal throat infection and the one which follows the skin infection. Group A beta hemolytic streptococcal throat infection, that is your pharyngitis. Then group A beta hemolytic streptococcal skin infection, that will be impetigo. Right, that will be impetigo. So whenever the individual gets infected, that is either throat infection or the skin infection, immediately there will be activation of the complement pathway. And that complement pathway which is activated, that will initiate the glomerular injury. Right, that will initiate the glomerular injury. Now, you take this both of them, that is group A beta hemolytic streptococcal throat and as well as the skin infection. The group A beta hemolytic streptococcal throat infection, this is more common in winter. And group A beta hemolytic streptococcal skin infection, this is more common in summer. Okay. And you, at the same time, you should know the serotypes. The common serotype, the one which is responsible for your throat infection, it is serotype 12. We have many other serotypes, but the common one is your serotype 12. What are the other serotypes apart from 12? 1, 2, 3, 4, and then we have serotype 25. Then the common serotype causing skin infection, that will be serotype 49, right? And apart from this serotype 49, we have many other serotypes as well. That is serotype 2, then we have 47, 55, 57, and then 60. These are the serotypes. Now you need to know the latent period. So it is not like immediately after throat infection, the individual is developing glomerulonephritis. So you have a latent period. So latent period for throat infection and latent period for the skin infection. Latent period for the throat infection, that is nearly around 1 to 3 weeks. Whereas the latent period for the skin infection, that will be around 3 to 6 weeks. Okay, that will be around 3 to 6 weeks. So these are the differences between your throat infection, that is pharyngitis, and skin infection, that will be impetigo. Okay, so these are the differences, right? Now, following this group A beta hemolytic streptococcal throat or the skin infection, what will be the presentation in these patients? What will be the clinical features in them? Right, first of all, what did I tell you? That this is the one most commonly seen in children. What is the age group? That is around 5 to 12 years is the age group. Then the presentation is what? The clinical features, they include secondary to your glomerulonephritis, they develop significant hematuria. And what will the child come with? Cola colored urine. And in order to have this cola colored urine, they should have gross hematuria. And there is proteinuria. Because of proteinuria, they will have edema. Right? And another important point is these patients, they have renal insufficiency. And because of renal insufficiency, there is fluid overload causing hypertension. And because of hypertension, there can be development of left ventricular failure. And as a part of left ventricular failure, they will have dyspnea. Right? They'll have dyspnea. Okay. Then the next important is they will also have ascites. That is because of the fluid overload. And not only ascites, because of the fluid overload, they also develop edema. That is pitting type of pedal edema will be there. And this dyspnea is due to what? That is due to pulmonary edema. Why there is pulmonary edema? Because of development of left ventricular failure. Why there is left ventricular failure? That is because of hypertension. And hypertension is mainly because of renal insufficiency. And that renal insufficiency is secondary to glomerulonephritis. So these are the clinical features. Coming to the workup, that is the investigations. So what will the child says? Having cola colored urine, the age group around 5 to 12 years or 5 to 15 years. And when you do a urine analysis in this patient, right? What will the urine analysis show? Presence of hematuria. And this hematuria, it's significant hematuria. That is more than 100 RBCs per high power field. And the urine analysis will also show the presence of proteins. They will have proteinuria also. But when you do a culture, most of the times it will be negative. Why? Because it is not the immediate infection causing glomerulonephritis. There is a latent period, right? For the throat infection, the latent period is around 1 to 3 weeks. And for the skin infection, the latent period is almost 3 to 6 weeks. So after the latent period, there is development of your glomerulonephritis. So the culture will be usually negative. And when you estimate or test the complement levels, the complement it is utilized. So that is the reason why in 90% of patients, there will be hypocomplementemia. There is decreased C3 levels. But this hypocomplementemia will be there for 1 to 2 weeks. After 1 to 2 weeks, the complement will, your C3 will return back to normal. But within how many days the complement will return back to normal? That is within 4 to 8 weeks after presentation. Four to 8 weeks after presentation, the complement levels will return back to normal. And what will happen to the serum creatinine levels? The serum creatinine levels, they are elevated. Then you also need to test the serology. So if you do the serology, what is that you need to check for? The antibodies. What will be the antibodies that will be formed in the pharyngeal infection? And what will be the antibodies that will be formed in the skin infection? You see the antibodies in the pharyngeal infection. The antibodies in the pharyngeal infection are the ASO titer is elevated, right? That is very important. Then the other antibodies that includes anti-hyaluronidase, right? Then followed by that anti-DNase B levels, they are elevated. Then anti-NAD. Okay, so these are the antibodies that are elevated in pharyngeal infection. Now, what are the antibodies which are elevated in the skin infection? In the skin infection, it is anti-hyaluronidase which are elevated. Then anti-DNase B. In skin infection, your ASO levels are not elevated. Okay, only in pharyngeal infection, the ASO levels are elevated. But whatever it is, what is the investigation of choice? The investigation of choice will be renal biopsy. Now, what does the renal biopsy? You have to observe that renal biopsy under light microscopy, electron microscopy, and then fluorescent microscopy. So in the light microscopy, you will notice that there is diffuse proliferative glomerulonephritis. Right? Light microscopy, it is diffuse proliferative glomerulonephritis. What will be there in that? You will have the presence of numerous neutrophils. You will have the presence of numerous neutrophils, right? And you also have deposits. Where will be these deposits? These deposits, they are present in the mesangium. So the neutrophils and deposits in the mesangium, that will give you the characteristic starry sky appearance. So can anyone tell me starry sky appearance in the CT scan, where will you have? Starry sky appearance in the CT scan. What is the condition? Very good. That is neurocysticercosis. Starry sky appearance in the lymph node biopsy. That is your Burkitt's lymphoma. Starry sky appearance in ultrasound abdomen. Starry sky appearance in the ultrasound abdomen. Yes, or ultrasound of the liver. in case of hepatitis, that is in case of viral hepatitis, or like in case of cirrhosis of liver, you get that starry sky appearance. Okay, right. So lymph node biopsy, CT scan, then ultrasound of the abdomen, and one more starry sky appearance is there. What is that other investigation? Lymph node biopsy, USG, kidney biopsy. I'll ask that. Okay, so you will have the starry sky appearance in the light microscopy, and if there are presence of crescents within the light microscopy, that tells you that actually the crescent formation is uncommon in case of post-streptococcal glomerulonephritis. But if there is presence of crescents, it tells the individual is having poor prognosis. Okay, so that is about your light microscopy finding. Then followed by that, the electron microscopy. Electron microscopy, it will show you the presence of subepithelial electron dense deposits. Right, presence of subepithelial electron dense deposits. And the presence of this electron dense deposits, they are referred to as humps. Right, they are referred to as humps. Okay, and what does these deposits contain? These deposits, they contain the immune complexes. Right, these deposits, they contain immune complexes. What is that immune complexes? IgG and as well as C3. But they are present in the deposits, but they cannot be observed in electron microscopy. Fluorescent microscopy is the one which will demonstrate the presence of IgG and C3. Right, fluorescent microscopy will show you the presence of IgG and as well as C3. Right, and this renal biopsy, it is usually not performed, as the clinical history is highly suggestive. Clinical history itself will give you a clear-cut picture, right? No, starry sky appearance in the light microscopy. Yes, Jacob, the starry sky appearance that you are seeing in the mesangium is in the light microscopy, right? And the history itself will give you the diagnosis that is highly suggestive. And the resolution of the inflammation will start 1 week after the presentation. Right, the resolution of post-streptococcal glomerulonephritis typically begins within 1 week of presentation. Okay, so this is about the biopsy picture in patients with the post-streptococcal glomerulonephritis. Right, next. Now, this starry sky appearance, right, it is observed light microscopy and even in the fluorescent microscopy as well. Okay, actually you have 3 patterns in the fluorescent microscopy. What are the 3 patterns in the fluorescent microscopy? One is Garland type. Garland type is what? Where the peripheral capillary loops, they are like stained with IgG and C3. That is your Garland type. Second one is starry sky. Right? The second one is starry sky. Starry sky is that where you have irregular deposits in the mesangium. Third one is mesangial deposits, right? Where you have IgG, C3, predominantly C3 within the mesangium. These are the 3 immunostaining patterns actually. What are those? Garland type, right? Where you have the staining of peripheral capillary loops. Second one is starry sky. And third one is mesangial. Okay, right? Yeah, wire loop, whatever you're telling, Jacob, Like that is Garland type. Okay. Next. Right. Then, so what did we discuss? Most of the times, biopsy is not required because biopsy is not required. Diagnosis is mostly clinical. But what are the indications of renal biopsy? Right? Indications of renal biopsy in glomerular diseases. Okay. Now, what did we discuss? That complement levels should return back to normal. That hypocomplementemia, whatever is there, that should return back to normal within 4 to 8 weeks, right? Maximum within 4 weeks, that is with 1 month, that hypocomplementemia should return back to normal. But if there is persistent low complement, that is low C3 levels, right? If there is persistent low C3 levels beyond 6 to 8 weeks, it's an indication for doing, or it's an indication for going ahead with the biopsy. Why? Because you need to think of a possible alternative diagnosis. Next, if the patient is having recurrent episodes of hematuria, normally recurrence in case of PSGN, it is rare. Episodes, recurrence will not be there in PSGN, very, very rare. But if there is recurrent episodes of hematuria, then it's an indication for the biopsy. And if there is recurrent episodes of the hematuria, what is it suggestive of? It is suggestive of IgA nephropathy. Right, it is suggestive of IgA nephropathy. And if there is progressive increase in serum creatinine, right? Progressive increase in serum creatinine. Because progressive increase in serum creatinine is not the characteristic feature of your post-streptococcal glomerulonephritis. But if it is happening in this patient, then you need to do biopsy and you need to check for what is the cause. Okay, these are the indications of renal biopsy in this glomerulonephritis. Coming to the treatment. So treatment, if you observe in these patients, as such, there is no specific therapy. Like for example, in Goodpasture syndrome, like we have plasmapheresis and corticosteroids are given. But here there is no specific therapy because it's immune complex mediated, which is causing glomerulonephritis. Okay, so there is no evidence indicating that aggressive immunosuppressive therapy has a beneficial effect in these patients, right? There is no role. Okay, there is no role of immunosuppressive therapy. Now tell me, is there any role of antibiotics? Is there any role of antibiotics? There is no role of antibiotics also. Why? Because the infection whichever has occurred, it is not the present infection. It is not the present infection. It is the infection almost like 3 to 6 weeks back. Now there is no role of antibiotics. Management is completely supportive. Like if the patient is having pulmonary edema, secondary to left ventricular failure, then give diuretics. And if the patient is having hypertension, give antihypertensive, that is labetalol. Okay. Which other cardiac conditions we give labetalol apart from hypertension? I'm talking cardiac condition. Which other cardiac conditions we use labetalol apart from hypertension? Any one of you? We have discussed this in cardiology. Actually, drug of choice for that condition is esmolol, but esmolol availability is not there. So we give alternative labetalol. Very good, Soumya. Excellent. That is aortic dissection. What are the classifications for aortic dissection? We have discussed two classifications for aortic dissection. Can anyone tell me? Very good. So one is your DeBakey, the other one is Stanford classification. What is the characteristic presentation in patients with aortic dissection? Characteristic clinical presentation. Right? That is tearing type of pain. That is tearing type of pain that will be initially in the retrosternal area that will be radiating to the interscapular regions. Right? Now, in these patients with the in aortic dissection, what is the most common risk factor for the development of aortic dissection? Most common risk factor. Very good, Vinita and Hari. So that is the hypertension. Hypertension is the most common risk factors. Right, very good. So all of you are answering. So that is hypertension is the most common risk factor. What are the connective tissue disorders which can cause aortic dissection? Connective tissue disorders. Marfan's and Ehlers-Danlos syndrome. Marfan's and Ehlers-Danlos syndrome. Okay. What are the valvular abnormalities associated with aortic dissection? What are the valvular abnormalities associated with the aortic dissection? Yes. Very good, Jacob. That is aortic regurgitation. Now, which type of dissections are more dangerous? Type A or type B? Type A. Type A dissections because there is involvement of ascending and as well as arch. Right? When there is involvement of ascending, there can be coronary artery dissections causing MI. And when there is involvement of arch, this cerebral circulation can get affected. So type A dissections, they are very, very dangerous. They require immediate surgical intervention. How much is the target blood pressure? Why are we giving labetalol in this patient? Why are we giving labetalol in patients with aortic dissection? Yes. Because not permissive hypotension, you need to keep the blood pressure, systolic blood pressure around 100 to 120. That is within the normal limit only, because the lower limit of your systolic is 90, right? Or even 100. So you need to keep the systolic blood pressure between 100 to 120, and the heart rate should be around 60 or 70. So labetalol is what it is, both alpha plus beta blocker. That is the reason why we give labetalol here. Okay, that will reduce hypertension and that will reduce heart rate as well. And what is another example of alpha plus beta blocker apart from labetalol, and where do we use that? Apart from labetalol, what is another alpha plus beta blocker and where do we use that? Very good, Manisha. That is carvedilol. Where do we use carvedilol, Manisha? Yes, Monisha. Very good, Dinesh. Used in congestive cardiac failure. Carvedilol is the one used in congestive cardiac failure. Okay, good. Okay, so here for hypertension, we need to give labetalol. And the other thing is, because these patients, they are having fluid overload. They are having the fluid overload. So for that reason, sodium and water restriction. There is salt and water restriction. And along with that, I already said you should give loop diuretics, mainly when the individual develops pulmonary edema. How will be the prognosis in these patients? Prognosis in these patients is complete recovery occur in more than 95% of children. Right? Complete recovery occurs in more than 95% of children. And what about the recurrence? Recurrence is rare in these patients. Right? And coming to the prevention. So, if you give early systemic antibiotic therapy for streptococcal throat or skin infection, that does not eliminate the risk of glomerulonephritis. Okay, so early systemic antibiotic therapy does not eliminate risk of post-streptococcal glomerulonephritis. Okay, so that is about your PSGN, post-streptococcal glomerulonephritis, right? Right. So now let me just quickly recap the topic of the post-PSGN, and then we'll move on to the Burgess disease, which is nothing but your IgA nephropathy. So PSGN, it is the one which follows both, right? It follows both group A beta hemolytic streptococcal skin and as well as throat infection. And it is most commonly following streptococcal, and occasionally it can be even staphylococcal infection as well. And it is predominantly seen in children. And the group A beta hemolytic streptococcal throat infection is most common in winter, and it is serotype most commonly 12. And group A beta hemolytic streptococcal skin infection is more common in summer, and most common serotype is serotype 49. And the pharyngitis, after pharyngitis, the latent period is 1 to 3 weeks, and after skin infection, the latent period is nearly around 3 to 6 weeks. And the throat infection we call pharyngitis, skin infection we call impetigo. And the age, as I have said, is in children 5 to 12 years of age. And these patients, they have sudden onset gross hematuria where they'll have cola-colored urine. There will be pleural effusion, pulmonary edema, because of which they'll have dyspnea, and they will also have renal insufficiency. And on examination, as I have said you, that they will have ascites and edema. And on auscultation, there can be also bilateral crepitations because of the pulmonary edema. Workup urine analysis will show you the hematuria, significant hematuria will be there, proteinuria, and cultures are usually negative. And complements, they are depressed C3 will be there for 1 to 2 weeks. And by almost like 4 weeks, this complement will return back to normal. The serum creatinine levels are elevated, and in the serology, the antibody titers are increased. Particularly in pharyngeal infection, you have ASO, anti-DNASB, anti-NAD, anti-hyaluronidase levels elevated. In skin infections, that is mainly anti-DNAs and anti-hyaluronidase titers are elevated. Investigation of choice will be biopsy. The biopsy, the light microscopy show you that there is diffuse proliferative glomerulonephritis and numerous infiltration of the neutrophils. And if there is presence of crescents, that is associated with poor prognosis. Electron microscopy, you will have subepithelial deposits and humps. And fluorescent microscopy, you have that starry sky appearance, the IgG and as well as C3. And next is indications of renal biopsy will be persistently low C3 levels, recurrent episodes of hematuria, progressive increase in serum creatinine. And as such, there is no specific therapy for PSGN. Right? For hypertension, you need to give labetalol, and for pulmonary edema, you need to give diuretics. And salt and water restriction should be done mainly to control the fluid overload. The prognosis, if you see, complete recovery will occur in 95% of the children, and recurrences are rare. And what type of hypersensitivity reaction is this? It's a type 3 hypersensitivity reaction. Okay, right. So that is about your PSGN. Now, if you see this IgA nephropathy, The another name for this IgA nephropathy, this is also called as mesangial proliferative glomerulonephritis. Right, mesangial proliferative glomerulonephritis. Okay, so as the word itself tells you that there is proliferation of the mesangial cells. Now, among all these antibodies, tell me what is the first line of defense by our body? What is the first line of defense by our body? Anyone? Very good. That is IgA. Sorry. So if you take the etiology of IgA nephropathy, the etiology is the individual will give you the history of upper respiratory tract infection or gastrointestinal tract infection or the urinary tract infection. Right, we'll give you history of URTI or GIT or the urinary tract infection. Now, within 2 to 4 days of either upper respiratory or gastrointestinal or the urinary tract infection, these patients, they present with gross hematuria. Why do they develop this gross hematuria? Against this upper respiratory tract infection or GIT or urinary tract infection, the first line of defense, IgA, is being formed. This IgA which is formed against that upper respiratory or GIT or UTI will accumulate in the glomerulus causing glomerulonephritis, and thereby these patients will have gross hematuria. And the type of hematuria that you will have is right, the type of hematuria that you will have is recurrent gross hematuria. That is what you will observe here. And where do you see this IgA? The IgA, right, it is deposited within the mesangium. IgA is deposited within the mesangium. And some of the very important points about this IgA nephropathy are, IgA nephropathy, it is the most common form of primary glomerular disease all over the world. And if the question is asked, what is the most common cause or what is the most common glomerular disease causing gross hematuria, and that too recurrent gross hematuria? Right, most common cause of recurrent gross hematuria, that will be your IgA nephropathy. And the blood pressure in these individuals, absolutely normal, right? And these patients, the prognosis is not that good like what we discuss in PSGN. PSGN, actually the prognosis is good, but here almost 20 to 40% of patients, right, they progress to end stage renal disease, right? They progress to end stage renal disease. So this will be the clinical picture in these patients. And if you take the workup, that will be renal biopsy. And if you take the renal biopsy, what is that you will observe in the light microscopy, electron microscopy, and then fluorescent microscopy. Light microscopy, you will notice that there is mesangial proliferation. Right, you will notice the presence of mesangial proliferation. And in electron microscopy, you have deposits, that is mesangial and paramesangial deposits. Right, mesangial and paramesangial deposits. That is in the electron microscopy. And in the fluorescent microscopy, you have the presence of IgA. And not only that, you also have C3 in the mesangial. Okay, so that is what is your IgA nephropathy, which is also called Buerger's disease. And the presence of mesangial IgA, right, presence of mesangial IgA, that is the sine qua non for diagnosis. Right, that will be sine qua non for diagnosis. Okay, that means if there is presence of IgA, right, that tells in the mesangium, it is suggestive of your IgA nephropathy. And another, so this is about the workup. And what about the serum levels? The serum levels, please remember, they will have in the serum normal levels of C3. C3 levels, they are not affected in the serum. This is a very, very important point which will help us to differentiate. In PSGN, what will happen to your IgA levels, sorry, C3 levels in PSGN, right? In PSGN, the serum C3 levels are low, okay? So this point of normal levels of C3 in the serum, this will differentiate IgA nephropathy from post-streptococcal glomerulonephritis, right? That is about the C3 levels. What about the serum IgA levels? The serum IgA levels, there is no diagnostic value. Right, there is no diagnostic value about the serum IgA levels. Okay, it is only the mesangial IgA levels. Then, how will be the course of the disease? In PSGN, what did we discuss? That recurrence is absent. But here, in patients with IgA nephropathy, which is also called Buerger's disease, in them, you have clinical exacerbations and remissions. That means they have the presence of increased recurrence. Right, the recurrence is very high. Okay, that is a very important point in differentiating PSGN from IgA nephropathy. And because the recurrence is very high in these patients, almost 20 to 40% of patients, they go into a state of end stage renal disease, right? That is what is the treatment in the IgA nephropathy. Then, how do you treat these patients? The treatment, if you observe in these patients, you need to give combination of right. So you need to give the combination of steroids and cyclophosphamide. Right? And this combination should be given for initial 3 months. And after giving steroids and cyclophosphamide for 3 months, this should be followed by supplementation of azathioprine. And this azathioprine should be given for a minimum of 2 years. Okay. And when you give azathioprine for a minimum of 2 years, that will cause the preservation of renal function. Right? That will cause preservation of renal function. So that is about your treatment of IgA nephropathy. And if you take some of the differences between IgA nephropathy and PSGN, so on one side you have IgA, the other side PSGN. So IgA nephropathy, if you take the onset of hematuria, the onset of hematuria in IgA nephropathy, it is 2 to 4 days after upper respiratory tract infection. Whereas PSGN, the onset of hematuria, it is 7 to 21 days, right? That is basically like 1 to 3 weeks or 3 to 6 weeks following your upper respiratory tract infection or the skin infection. And what will happen to your serum C3 levels in IgA nephropathy? That remains normal. But in PSGN, these patients, they will have decrease in serum C3. Right? They'll have decrease in serum C3. But the decrease in serum C3 will be only transient. Okay, this will be only transient. And what about the recurrences? Recurrence, it is common in IgA nephropathy. It is rare in case of post-streptococcal glomerulonephritis. Okay, and in case of IgA nephropathy, there is no elevation of ASO titer. Right? But whereas in IgA nephropathy, there is elevation of ASO titer. Right? There is elevation of the ASO titer. Okay. So these are the differences between IgA nephropathy and as well as post-streptococcal glomerulonephritis. Right? So this finishes your the IgA nephropathy. I'll just quickly recap this topic. So IgA nephropathy, which is also called mesangial-proliferative glomerulonephritis, where you have the proliferation of the mesangial cells, right? And the other name for this IgA nephropathy, this is also called Buerger's disease. And what exactly is the etiology is not known, but in many cases, the patients present with gross hematuria after infection of respiratory or gastrointestinal or urinary tract infection, right? And this IgA, it will activate the complement pathway and damage the mesangial cells. So 2 days after or 2 to 4 days after the infection, the recurrence is common, complement levels are normal, and even the ASO titer is also normal. So your IgA nephropathy, that is the most common form of, or most common primary glomerular disease for recurrent gross hematuria. The blood pressure is normal. And in almost 20 to 40% of patients, they go into a stage of end-stage renal disease. Light microscopy will show you that there is presence of mesangial proliferation. And electron microscopy, you have mesangial and paramesangial deposits. Fluorescent microscopy will show you the presence of IgA and C3 in the mesangium. And presence of IgA in the mesangium is a sine qua non for the diagnosis. And the serum complement levels, they're absolutely normal. And serum IgA levels, they're absolutely normal. They're of not importance. There is no diagnostic value for serum IgA levels. In course, if you see, they have recurrences, they have the clinical exacerbations and as well as the remissions. The treatment is that you need to give steroids and cyclophosphamide for initial 3 months, followed by that you need to give azathioprine for a minimum of 2 years. Okay, so these are the points related to your IgA nephropathy. Okay, next. Now, after having discussed about your IgA nephropathy, let me take up the discussion of the renal vascular diseases. In the renal vascular diseases, we have 2 important renal vascular diseases, that is renal artery stenosis. Then we have, right? So the topics that we are due with, your renal vascular diseases, then polycystic kidney disease, and one more important topic, that is ciliopathies. Then we have the other topic, that is HUS, that is hemolytic uremic syndrome, and renal tubular acidosis. I will discuss them because I think I have one more session for acid-base disturbances and the electrolyte abnormalities. I think that the session is on November 1st. November 1st, I have the separate session for acid-base disturbances and as well as the electrolyte abnormalities. Yeah. So there I will discuss the renal tubular acidosis as well. Yeah. Yes, Rohita, I will be discussing about the high one. That is HIV-associated nephropathy, which is basically like your focal segmental glomerulosclerosis, actually. And then we have the hypertension-related renal pathologies. So these are the topics that we are due with now. And followed by that, as usual, like yesterday, like what we have done, multiple choice questions, we'll be doing the multiple choice questions in this as well. Coming to the renal vascular diseases first. So there are 2 important renal vascular diseases. That is renal artery stenosis then we have renal vein thrombosis. So if you take the renal artery stenosis, the etiology of renal artery stenosis, if you take in old patients, the most common cause will be atherosclerosis. Whereas in young patients, the most common cause, what is it in India? and in Western countries. In India, the most common cause of renal artery stenosis in young individuals, that will be your non-specific aortic arteritis, which is nothing but Takayasu arteritis. So Takayasu arteritis is what form of your vasculitis? Which vessels are affected? Large vessel vasculitis. Large vessel vasculitis. What is the difference between your giant cell arteritis and Takayasu arteritis? Age-wise. Now, Jacob, Takayasu is commonly seen in ages. Yeah, very good, Hari. So giant cell more than 50 years. Not 20s, less than 50 years. Less than 50 years. So even around 40, 45, you have this Takayasu arteritis, but less than 50 years. More than 40, 50 will be your giant cell arteritis. What is the most common vessel affected in Takayasu? What is the most common vessel affected in Takayasu? Right, that is not temporal, Soumya. Right? Temporal is in giant cell arteritis. That is temporal arteritis, right? Whereas here, it is subclavian artery. Subclavian artery is the most commonly affected vessel. And because of that, what will happen to the blood supply on the affected side? Blood supply to the upper limb on the affected side because of the involvement of the subclavian artery. The blood supply to the upper limb on the affected side will be reduced. And that is the reason why it is called pulseless disease. Very good, Manisha. So the another name for your Takayasu arteritis, this is also called pulseless disease. Okay. So the most common vessel affected is subclavian. Because of this, if you take the blood pressure in both the upper limbs, so you have difference in the blood pressure between the two arms. If you take, like, the most common is left subclavian artery, commonly affected in Takayasu. So left upper limb pressure will be less and right upper limb pressure will be normal. That is more than that of your left. Can anyone tell me what are the conditions where you have differences in the upper limb blood pressures apart from Takayasu? Apart from Takayasu, what are the other conditions where you have? Very good. Coactation. But where should be that coactation? Where should be that coactation? Where should be that coact? Very good. So proximal to the left subclavian artery, right? Yeah. Some other conditions. Not distal. Not distal. If it is distal to the left subclavian artery, you have difference in the pressures between upper limbs and lower limbs. But if the coactation is proximal to the left subclavian, then only you will have difference in between both the upper limbs blood pressure. Okay. Yeah. So now tell me your differential, I mean the other conditions where you will have difference in the blood pressures between both the upper limbs. One is Takayasu and the other, you said, like proximal to the coactation proximal to the left subclavian artery. The other one is supravalvular aortic stenosis. Supravalvular aortic stenosis, right? We, if I'm not wrong, I have discussed this in topic of hypertension, right? Supravalvular aortic stenosis also, you have difference in the blood pressures between both the upper limbs. That is what is nothing but your Coanda effect. I have discussed what exactly is the Coanda effect there. Okay. And then next, like this obstructive aortic arteritis, which is nothing but Takayasu. Okay. Right. And whereas in Western countries, what is the most common cause of renal artery stenosis? That is fibromuscular dysplasia. Right? Fibromuscular dysplasia. And this renal artery stenosis, what will be the presentation? Five percentage of patients, they present with secondary hypertension. right? And renal artery stenosis is responsible for acute or chronic renal failure. Does it cause acute or does it cause a chronic? Very good, Kiki. So it will cause chronic renal failure. Okay. And this hypertension, it is secondary to increase in the renin levels. Secondary to increase. So it is high renin hypertension. And this renal artery stenosis, it is bilateral in 50% of patients. It is bilateral. And the other important presentation in renal artery stenosis is recurrent flash pulmonary edema. Why do you get this pulmonary edema? First of all, the pulmonary edema will be there because of hypertension, right? So whenever there is hypertension, what will happen to the afterload on the left ventricle? The afterload on the left ventricle increases, and that will cause left ventricular failure. And this left ventricular failure is what is responsible for the development of pulmonary edema. And this pulmonary edema is cleared, right? The pulmonary edema is cleared with one dose of diuretic. Right? With one dose of diuretic, the pulmonary edema will be cleared. With one dose of diuretic, if the pulmonary edema is cleared, that is called flash pulmonary edema. That is called flash pulmonary edema. Okay. Then, how will you, on examination, what will be there in these patients? On examination over the abdomen, you will listen an abdominal bruit. And this abdominal bruit, that is because of your renal artery stenosis. And this bruit, it is heard during both diastole and as well as during systole. Okay. So basically it is like a continuous murmur, right? That is on examination. Then what is the workup that you need to do in these patients? So because of this hypertension, what will be the patient's presentation? Headache. And that too, occipital headache. Right, that too, the occipital headache. Okay. And the next important is the workup or the management. If you see the management in patients with renal artery stenosis, you need to know what are the investigations, and finally, how do you treat these patients? The investigations is that when there is bilateral renal artery stenosis, these patients, they go into a state of renal failure. Okay. The serum creatinine and as well as urea, both of them, they are elevated. Both of them, they are elevated. Then followed by that, you take the screening test. The screening procedure of choice. Right? Screening procedure of choice for renal artery stenosis is gadolinium enhanced 3-dimensional magnetic resonance angiography. That is a screening procedure of choice, right? That will give you a picture of renal artery stenosis. But what is it which will confirm? The confirmatory test. confirmatory test will be contrast enhanced arteriography. Okay, so this contrast enhanced arteriography is the one which will show you the presence of the renal artery stenosis. Then, how do you treat these patients? So, yes, Jacob, when do you want to start therapy? Basically, okay, let me tell you what is the treatment. If it is unilateral renal artery stenosis, we start ACE inhibitors. Okay, we start these ACE inhibitors even by just doing an ultrasound also. Ultrasound shows if renal artery stenosis is there unilaterally, we start ACE inhibitors. There's no doubt in that. Right. So, unilateral renal artery stenosis, you need to give the ACE inhibitors, right? And this we can start even by doing gadolinium enhanced MRI, even by doing ultrasound also you can start. But when is the requirement of contrast enhanced arteriography is required, I will tell you. So if suppose, if there is bilateral renal artery stenosis, can we give ACE inhibitors, Jacob? ACE inhibitors are contraindicated, right? Why? Why the ACE inhibitors are contraindicated if it is bilateral renal artery stenosis? Any one of you? Yeah. So when there is bilateral renal artery stenosis, already there is decreased glomerular perfusion. And when you give ACE inhibitors, what do these ACE inhibitors will do? These ACE inhibitors, they will cause efferent arteriolar vasodilatation because they are inhibiting angiotensin II formation. So efferent arteriolar vasodilatation will be there. So whatever that some amount of blood which is entering into the glomerulus because of renal artery stenosis, it immediately enters into your efferent arteriole because your efferent arteriole is dilated. So the blood from the glomerulus enters into efferent arteriole, thereby the glomerular perfusion will be reduced. So that is the reason why in bilateral renal artery stenosis, the ACE inhibitors are contraindicated. What are the other conditions where the ACE inhibitors are contraindicated? Yes. What are the other indications? Very good, Hari. In pregnancy, right? They are absolutely contraindicated. Then the other conditions where ACE inhibitors are contraindicated. Yeah, angioedema is the adverse effect actually. The other is hyperkalemia. When the individual is having severe form of hyperkalemia, then these ACE inhibitors are contraindicated. Pregnancy, hyperkalemia, absolute contraindication. Now, when, right, yes, Jacob, you're asking, sir, do we need to start treatment after doing these two investigations? When is this contrast enhanced arteriography required is when you are planning, see, because of this renal artery stenosis, what is the complication? There is recurrent flash pulmonary edema. So when there is recurrent flash pulmonary edema, now the treatment in these patients is you need to do PTRA. Right? What is this PTRA? That is percutaneous transluminal renal angioplasty. Right? Percutaneous transluminal renal angioplasty. So you will do PTRA when there is recurrent flash pulmonary edema. Prior to doing this PTRA, you need to do contrast enhanced arteriography. So mainly when you are starting the when you are planning to do an intervention, then you need to do both of these investigations. But if you want to start medical therapy or your ACE inhibitors, then in such case you don't require your contrast enhanced arteriography. Is that clear, Jacob? Right. So that was about the renal artery stenosis. Then the next important renal vascular disease is what? Renal vein thrombosis. Yeah. So for bilateral renal artery stenosis, they have increased incidence of recurrent flash pulmonary edema, right? That is the reason why PTRA has to be done. If recurrent flash pulmonary edema did not develop, then the PTRA is not required. Then PTRA is not required in these patients. Then for bilateral renal artery stenosis, what is the antihypertensive that you will give? Anyone? You need to give calcium channel blockers, right? Calcium channel blockers should be given. Even thiazides, we usually avoid. Why do we avoid thiazides? Because that will decrease the GFR. Okay, right. So preferably we give calcium channel blockers or we give labetalol. Okay, so that is about your renal artery stenosis. Next, coming to next important form of renal vascular disorder, that is the renal vein thrombosis. So if you take this renal vein thrombosis, so renal vein thrombosis, as the word itself is telling you, that is the formation of thrombus within the renal vein. But what are the predisposing factors for the development of renal vein thrombosis? Renal vein thrombosis, the risk factor for the development of renal vein thrombosis is it is preceded by gastroenteritis. Right, preceded by gastroenteritis. What this gastroenteritis will induce? These gastroenteritis will cause dehydration. And as a part of the dehydration, there can be stasis of the blood, and that can cause the hypercoagulability. Okay. And the other etiologies are hypercoagulable states. Right. So these are hypercoagulable states are what? Antithrombin 3 deficiency, protein C proteinase deficiency, right? The individual taking high amounts of estrogen supplements. So that will be the etiologies. And what will be the problem in renal vein thrombosis? They develop post-renal cause of acute renal failure. Right? Post-renal cause of the acute renal failure. And how will be the kidneys in these patients? The patients with renal vein thrombosis, they have impairment of venous drainage. Because of impairment of the venous drainage, what will happen to the size of the kidney? Very good. So, size of the kidney is enlarged. Okay, there is marked enlargement of the kidneys. There is marked enlargement of the kidneys. Right. Then the next important is Doppler flow study. That is to confirm the diagnosis. How can you make out that the kidneys are increased in size? That is by ultrasonography. And Doppler flow study, that will be the screening test, right? But what is that which will confirm the diagnosis? Angiography of the inferior vena cava. Okay, that will confirm the diagnosis. And how do you treat these patients? The treatment is anticoagulants. But regarding the etiology, there are a few more points to be discussed regarding the etiology. So what did we discuss? One is the preceded by gastroenteritis, then hypercoagulable states. What will be that hypercoagulable states? Like your pregnancy, taking oral contraceptive pills rich in estrogen, dehydration. Even malignancy is also, that is renal cell carcinoma. That is another important etiology. But if the question is asked, most common cause of renal vein thrombosis, that will be membranous glomerulonephritis. Okay. And apart from that, the other renal pathologies will be lupus nephritis and amyloidosis. Right? Lupus nephritis and amyloidosis. Okay. And the other etiologies, like, as I have said you, renal cell carcinoma, intake of oral contraceptive pills, and that too they are rich in estrogen, right? And then dehydration. That is your gastroenteritis, already we have discussed. These are the etiologies for the renal vein thrombosis. So this completes your renal vein thrombosis. Basically, you have to remember that the individual will progress to a state of the post-renal type of acute renal failure, and the kidneys are enlarged in size. Okay. So with this, we are done with the topic of renal vascular diseases. Why not CECT for confirmation of the diagnosis? Okay. So when you are giving the contrast in a suspicious case of renal vein thrombosis, let us just assume you are giving a contrast. Jacob, tell me, what is the effect of contrast on the kidney? What is the effect of contrast on the kidney, Jacob? Right? So contrast is nephrotoxic. Already in renal vein thrombosis, there is increased risk of acute renal failure. So can we give a contrast in a patient in whom you are suspecting that there is development of acute renal failure, Jacob? We don't give. So CCT abdomen, we don't prefer. So the best is the invasive procedure that will confirm the diagnosis. Okay, right. So that completes the discussion of the renal vascular diseases. Just take a lunch break, right? We'll reassemble back. It's 1:50 now. So we'll reassemble 1:10 now. So we will reassemble back again at 2 o'clock and discuss the remaining topics. That is your hypertension related, hemolytic uremic syndrome, then few more topics, whatever are there, like we'll try to take up. But the renal tubular acidosis, please remember, you people were asking about the hereditary disorders of the kidney. That is Gitelman's and Barter's. I'll just give you a quick overview because there are actually the pediatric nephrology cases because they are hereditary cases. But anyways, I'll just cover from my side as well. And renal tubular acidosis, as I have said you, I'll be discussing that in the acid-base disturbance, and very important, polycystic kidney diseases. Okay,